Welcome to this deep dive session sponsored by Meril. We're going to talk 90 minutes about the Landmark randomized controlled trial, which was masterly presented this morning by our chairman, Patrick Serras. Incidentally, who was in the room when the Landmark was presented? Half of them. Okay, so some of it will be repetition, but we'll go into questions that came up. Patrick, why don't you give us the objectives and introduce the panel?
So that's a little bit the agenda, early outcome of randomized trial. That will be Andreas Bombach. And then we will go to a lot of questions. Is Landmark contemporary trial? Close look at the baseline characteristic. That will be Niels van Rooyen. The significance of intermediate size according to multi-slice statistician recommendation, that will be Ignacio. Then the real-world representative case from Landmark. Then insight from quantitative orthography and procedure and echocardiography at pre-discharge and 30 days, that will be Osama Soliman. Why and how the conduction disturbance were treated, that will be Yoshi Onuma. And added value, I'll try to see what is the added value. So this is the people who are either speaker or discussant. We have around the table, let me see if everybody is there. We have Mathieu Bunk, Martin Udek. I don't see Axel Link, but maybe they will come later. I think that's it. So I give the floor to Andreas Bombach. Yeah.
So what we want to do with this is to further understand the patient cohort that was included, to investigate how the multi-slide CT scan guides the selection, to assess the respective value of periprocedural aortography and echocardiography pre-discharge and at 30 days, to further understand what kind of conduction disturbance, that was a question, leads to permanent pacemaker implantation, and to put in perspective the added value of the MyVal TCR series. Now, this is mostly now for those of you who didn't attend, and for those of you who attended this morning, this might just be an educational repetition. This is basically what was presented this morning, and I don't have any potential conflict of interest in relation to this presentation. We had the background presented, and the study was started because the major evidence of TAVI has been mainly obtained with SAPIEN and Evolute HV series, positioning these two heart valves as the contemporary standard. They were called gold standard in the discussion. The MyVal series, as you've seen and will see, is a novel balloon expandable THV series whose favorable outcomes have been shown in observational studies but not in a randomized trial. And the Landmark trial is the first head-to-head randomized trial comparing the safety and effectiveness of MyVal THV series with the contemporary THV series, which will be SAPIEN and Evolute, and we'll go into the details of that. You've seen how the study was executed. The chairman was Patrick Serras. I was the global PI. We had a clinical event committee down here. We had the CORIP core lab in Galway doing the imaging analysis. Circ will speak about the ECG, and we had a data and safety monitoring board led by Franz Josef Neumann. And if I'm not mistaken, I'll get the top 10 recruiters here in an additional slide. Niels van Rooyen with 110 leads the field. Ignacio Amat Santos, Dr. Martin Hudec, Professor Maciej Bunc, Dr. Iselmuden, Dr. Larmetz, Dr. Unik, Professor Merkel, Dr. Hermanidis, and Dr. Ninos were the top 10 recruiters for this trial, and we thank them again for their massive contribution. Landmark, to remind you, was a prospective randomized multicenter open label non-inferiority trial, and patients with severe native aortic stenosis requiring TAVI were randomized. It was a 1-to-1 randomization between MyVal and the contemporary THV series, and the allocation was such that in the contemporary THV series we have equal numbers of SAPIEN and Evolute. The primary composite endpoint is at 30 days. We've heard that's mainly a safety endpoint, but there will be pre-specified analysis at 6 months, 1 year, 2 years, and the patients will be followed up throughout 10 years. MyVal, for those of you who haven't seen it, is a valve that has diameters, it's intermediate diameters, and this is not achieved by a different balloon size like we know it from stents, but these are custom made to this specific diameter. So there's a range from 20 to 32 in 1.5 millimeter increments, and that is a specific of this valve. And as you can see on the left, the majority of the implants was MyVal, and there were some of the new iteration octa-core. In the SAPIEN, we have 4 sizes, and we use SAPIEN 3 in the majority and some ultras. The Evolute you see in the lower range, there has to be a remark that the smaller Evolute wasn't used. The larger sizes, 30.5, 32 in the MyVal series, they were going into an ongoing registry. They were not randomized because they were too big. There was no comparable valve available in the Evolute, in the SAPIEN range. Is intermediate sizing being used? This is the Landmark population. In blue, you see the intermediate sizes, so almost half, and that reflects clinical practice, and also studies on the right that have looked into this. So if you have the intermediate sizes, you use them in half the patients. Sample size calculation might be boring, but is very important for a randomized trial. So this was a non-inferiority trial with an assumed event rate of 26.1% for each group based on experience in other trials, a non-inferiority margin of 10.44%, which is 40% of the event rate, which is what the FDA recommends, a one-sided alpha of 5%, a power of 93%, which is high, leading to a sample size of 768 subjects. The eligibility was basically needing a heart valve and being and having a suitable anatomy for all 3 valves in the specified size range. So I sat on the committee that looked at all the cases that were proposed, and we hardly ever turned one down. The majority of cases that were not randomized went into the oversized registry. Now, the primary composite safety and effectiveness endpoint at 30 days was the VARC3 criteria, which we had extensively discussed this morning, a composite of mortality, stroke, bleeding, 3 and 4 VARC type, kidney injury, major vascular complications, moderate or severe prosthetic regurgitation, or conduction system disturbances leading to a pacemaker. The baseline characteristics, a typical cohort for TAVI patients, TAVI for aortic stenosis, 50% in NIHA class 3 or 4. The STS risk score median 3% in both groups. There was no difference in the groups, and there was no difference in the additional medical conditions in these groups. The echo and multi-slice baseline assessment, just the main things. It is aortic stenosis. The mean peak velocity was 4 meters per second, for example, and the mean annulus area was 471 square millimeters in both groups. Just to mention 6%, 7.5 bicuspid valves, they were not excluded. Now, this is the essential probability plot, the result. I'll quickly go through them. So the absolute difference for the primary endpoint was minus 2.3%. And to cut the statistics short, the upper one-sided confidence interval was well below the non-inferiority margin, and the target was met, non-inferiority, with a p-value of less than 0.0001. And the essential results of the primary endpoint and the primary endpoint defining sub-endpoints here in this forest plot, everything to the left favors the MyVal series, and everything to the right would favor the contemporary series. And you can see they're all hitting the line here with some numeric benefits for the MyVal series regarding valve regurgitation, new pacemaker implantation, and some bleeding risk benefits or kidney injury in favor of the contemporary. But statistically, they're the same. And finally, the effective orifice area of the MyVal versus the others. This is echocardiographic assessment. This one is an outlier up here. That's one implant. But I'll show you this graph like this. The red are the 20, 23, 26, and 29 millimeter Sapiens, and the green are the 1.5 increment of the MyVal series. And you can see it's not only different, favoring the MyVal, it's statistically different in 23, 26, and the 29 range. Looking at the Evolut, which we all know has favorable orifice areas, they are pretty much the same in the used size range. So these are all three together. So this will be published next week in the Lancet, and the summary is that the Landmark trial is the first really head-to-head trial comparing two balloon expandable valves and one self-expanding valve based on VARC-3 criteria. Again, that's important. The Landmark trial has expanded the indication of TAVI to those with complex anatomy, small annuli, and bicuspid valves, and this is a true all-comer study. The Landmark trial establishes the non-inferiority of MyVal compared to contemporary THV series for early safety and effectiveness composite endpoints at 30 days. And finally, when we compare the effective orifice area of conventional sizes, the MyVal showed even or significant larger orifice areas than the Sapien series and similar to Evolut. The availability of intermediate sizes enables precise and appropriate matching of devices to an individual patient's anatomy and was used in almost half the patients. And continued follow-up to 10 years will unravel whether the documented effective orifice area of the MyVal will have a beneficial impact on the long-term patient prognosis and valve durability. Thank you very much for your attention.
Okay, so that was perfectly on time. That's always good for the discussion. So the next speaker will be Niels van Rooyen, the top recruiter in this trial, and he will address the question, is the Landmark trial a contemporary trial and a close look at the baseline characteristic and compare to other trial? Niels?
Yes, thank you very much, Patrick. Of course, it's a big pleasure and honor to take part in this deep dive session today. But to be honest, it's also a little bit of a relief, and that has to do with the fact that I think I have never been involved in a clinical trial for which so much data, so much detail was asked for, had to be provided. And sometimes my trial nurses, they were really close to crying. But we're here today, we made it. And of course, that's also, I think, the strength and the beauty of this trial, that we have all these data. And it will certainly provide us with very important insights also beyond the primary outcomes as just presented by Andreas. So these are my potential conflict of interest and a general statement on the products of Meril. I think first it is important to realize that over the past years there has been only very few RCTs that have compared different TAFI platforms in a head-to-head manner. They are listed here. It's actually maybe a handful of RCTs, which is of course totally different to what we're used from the PCI arena, for example. And also, most of these RCTs had very stringent inclusion and exclusion criteria. However, as you all know, as operators in the real world, it's different. Their TAFI procedures are performed in a diverse patient population, varying comorbidities, anatomical complexities, and procedural nuances. And in that respect, the Landmark is probably the most comparable to a real-world setting as compared to the other RCTs, because, and that was already pointed out by Andreas, the decision to include a patient in the trial was left on the heart team's discretion. Now here are some of these common exclusion criteria listed as they were used in previous RCTs, and this includes, for example, presence of a bicuspid aortic valve, severely depressed left ventricular ejection fraction, mitral regurgitation or mitral stenosis, severe renal insufficiency, or previous stroke or myocardial infarction. This was completely different in the Landmark trial. Landmark trial only had two exclusion criteria, namely patients not willing to provide informed consent, naturally, and the other was formulated as any condition which, in the investigator's opinion, would preclude safe participation of patients in the study. On the other hand, very, very broad inclusion criteria. So all patients with an age over 18 years, patients, of course, had to provide written informed consent, but the third bullet point is the most important. As per local heart team assessment, patients had to be eligible for TAFI and suitable for implantation with all three study devices. And that's it. So this should provide also a very much real-world-like cohort in the Landmark trial. Now, in order to test that, it is of course best to compare the characteristics of the Landmark with the characteristics as they are available from the real-world registries. And such registries are luckily widely available. So there are several registries from Europe, from Spain, from France, also the Gary from Germany. The very large DVT registry from the US, I think almost 300,000 TAFI patients in that registry, but also international collaborations like the Central Collaboration. And as you can see, for example, age in the Landmark trial was rather high at 80, but this is very comparable to what we know from the large TAFI registries. Another example, gender. To me, it was quite surprising how well balanced gender is in the TAFI cohort, very different, for example, from the PCI cohort. And this was also observed in the Landmark trial, so almost perfectly balanced. 48% of the patients were female, 52% of the patients were male. Comorbidities are very high in the TAFI population. Diabetes, coronary artery disease, hypertension, very high rates of hypertension, and a similar pattern also in the Landmark trial. Then the risk score, so the STS scores, what we have observed over the last years is a decrease in the STS score of the TAFI patients. And this is also reflected by the STS score in the Landmark, which was rather low at a median of 3. Then challenging anatomies, native bicuspid. For those of you who were in the session this morning, you've seen how important this is, also based on the results of the Notion 2. In general, bicuspid anatomy, the incidence is low in the registries. It was also relatively low in the Landmark at 7%, but certainly not lower than what we know from the large registries published so far. And then finally, the small annuli, also a hot debate now, especially after the release of the data from the SMART trial. In general, it's not available for all registries, but well, varying between 25 and 40%. And in the Landmark, we had 1/3 of the patients with a small annuli. And the majority of these patients also comparable to the SMART trial, for example, the majority of these patients were female patients at almost 85%. So to conclude, the Landmark patients indeed resemble real-world patients, and this has to do with the fact that the primary selection was done by the heart team at the respective study centers. The mean STS PROM score was relatively low, but this reflects contemporary practice. Challenging anatomies like small annuli and bicuspid anatomy were included, and this permits sub-studies later on. And finally, and this is more a general remark, I think it is really important to perform head-to-head trials for TAFI. These are crucial to increase our knowledge, and most importantly, of course, to improve the quality of our patients' lives. Thank you very much for your attention.
Thank you very much. We move on to the next talk before the discussion of both talks. Ignacio Amat Santos will tell us how these intermediate size valves actually performed.
Thank you very much for the opportunity to present the results of the intermediate size cohort, which is one of the unique features of this MyVal THV technology. I want to join Niels in the relief of ending this stage of the study, but it's 10-year follow-up, Niels. I'm sorry. This is going to be very hard. So I want to present this on behalf of all the investigators, also the co-investigators, the hundreds of investigators that are behind doing all the tough job that takes a study so relevant as this one. So these are the disclosures. MyVal THV series have the conventional sizes, but also the extra large sizes and 6 intermediate sizes. So it's an increase in 1.5 millimeters from size to size, which is the rationale behind these sizes is that this can help to reduce the risk of paravalvular leak or conventional or conduction disturbances, thanks to an adequate sizing, thanks to less under or oversizing. But potentially, this could also reduce some life-threatening complications as annular rupture. It's very difficult to demonstrate this because it's a strange complication, it's uncommon, so finding statistical significance is difficult, but this is, again, a rationale that makes sense behind this concept. This is a chart that you have already seen. These are the devices that were included. Apart from the conventional sizes, we have the 3 intermediate sizes. And no cases were performed with the Evolut 23 millimeters. And if we see what we have done in the centers, you can find that almost half of the patients were treated with intermediate sizes, and this was selected by the investigators. Indeed, in centers including 15 patients or more, at least 40% of the patients were treated with intermediate sizes, up to 67% in one center, which is my center. Does this have an impact on post-dilation? Well, this is something that needs further investigation for sure, but we found that the rate of post-dilation was 12% in intermediate sizes compared to 21% in the contemporary THV series, and this was significant. And in the intermediate sizes, the regurgitant fraction was above 17%, was not above 17 in any patient, meaning no moderate or severe leak in any of the patients in the intermediate sizing compared to 19 cases in the contemporary THV series. In this figure, we can see the size of the aortic annuli by MDCT, and the post-procedural effective orifice area. The MIVAL THV series, you can see there in green, had a greater progression of effective orifice area compared to the contemporary THV core. And if we see, compared to the alternative devices, when we compare to the SAPIEN THV series, the progression of the effective orifice area with MIVAL was greater, and it was also larger for every specific size of the aortic annulus. We will see this in further detail. Comparing to self-expandable Evolut THV series, we can see again this greater progression of the effective orifice area with MIVAL, which can be only related to these intermediate sizes, with a very good performance, and despite the good performance of self-expandable devices that we know in smaller annuli. If we go size by size, when we compare the 20 millimeter balloon expandable devices, we can see that there were no differences in the effective orifice area. But this difference was significant for the 23 millimeter valve. Remember that no Evolut 23 was used in the trial. Again, it was significant when we compare the 26 millimeter valves, MIVAL THV series and SAPIEN series. But the difference between MIVAL and Evolut 26 was not different. And same thing for the 20 millimeter valve. There were no cases with the extra large, so we cannot do the comparison with the Evolut 34. This is very interesting if we compare the effective orifice area that we obtain with the intermediate sizes, because this effective orifice area correlates with the one size above for the SAPIEN THV series. So the 21.5 was similar to 23, was even better than 26 SAPIEN, and even better than the 27.5. So in conclusion, the intermediate sizes were used in almost half of the patients in the Landmark trial. These additional intermediate sizes allow a better sizing, less undersizing and less oversizing. It also was associated to a lower rate of post-dilation compared to the conventional THV series. It was associated to an immediate improved hemodynamics compared to the alternative. And this might be related in the follow-up to a better durability of the device. We have 10 years to verify if this is true or not, but we will. So thank you very much.
Very good.
Excellent. I think we'll have a round of questions and answers. I have two questions from the audience, which I'll quickly address. In bicuspid anatomy, how was randomization done? Same.
There were not specific randomization for the bicuspid. I mean, just central randomization for the type of valve, not for the anatomy.
Okay. And all comers is probably not a fair heading, as even in the top 10 include as low number of patients were shown. That probably is me and my semantics. It wasn't an all comers in the sense of every patient that was treated went into the study. You have heard it was a very intense study that just didn't go with the research personnel. All comers, I used this word in the sense of there was no real exclusion criteria.
Yeah. Right? I can say two things, is that in the Lancet you have the proportion of patient was done in all these institutions during that time. And don't forget that we went through the COVID. Fortunately, we all forget the COVID, but that was the time of the COVID. And I have to mention a litigation, a legal action, so that the British, the German, the Italian, and the Spanish could not participate all the time in the trial. That's a few limitations. Okay.
I think we've got.
What about you? Yeah.
So, congratulations on my behalf to all the investigators for this amazing work. I guess one of the features that amazed me is that superior hemodynamic performance of the valve. I mean, we see a balloon expandable annular valve exhibiting supraannular hemodynamics, which is pretty amazing. And given the recent SMART trial that really for small anatomies that were represented in this cohort, at least in 1/3 of the patients, the fact that we have superior hemodynamic performance has lifetime management consideration. One question is, how do we see that affecting our clinical practice in the future in terms of patient selection?
Well, I think I can say we've started using the valve, and what happens is you use the intermediate sizes. So 50% I think is a clinically realistic thing, and of course, if you have critical patients where you definitely don't want to oversize or undersize calcified, that's the situations where we now tend to try to optimize the sizing and choose the valve.
Yeah, if you look a little bit more, the hypothesis for an improved hemodynamic, you have, of course, the leaflet itself. Okay, you can have an animal which has a thin leaflet and an animal which has a thick leaflet. That play a role. We don't control that very much, but the industry control that. Then you have the cut of the valve, which is important. Then you have the suture, and I mentioned this morning that there was a paper in JACC Intervention on Resilia, which is the new generation of Edwards. And in the paper, there is a wonderful picture. You see two valves, the old generation of the Edwards and the Resilia. And you could see that the suture, which was very thick previously, is now very thin. And the fact that already 3 years ago, the company has a thin suture explained today that we are systematically superior. The anticalcic solution, that's more complicated, but that can have also an effect on the flexibility of the valve, yeah? And of course, for, like we said this morning, we have to wait the follow-up. I mean, we have to see if it's confirmed at 1 year, 3 years, 5, etc. Yeah.
May I have one question regarding, I mean, the trial showed definitely the need of intermediate sizes, and 48% of patients received that kind of valve. Do you think that may also give some advantages in long-term benefit to the patients as compared to conventional sizes? Maybe Ignacio.
No, I think that later on you will see what we call something that Axel has created. Where is Axel? Yeah, he has suggested during the process of rewriting the Lancet paper, he said, why you don't create a fitting index? And I said, what do you mean by fitting index? And then he gave the formula, which is basically the nominal size by the diameter derived from the multi-slice CT scan, either from the area and the perimeter. And you will see this result later. You will see already some impact of the fitting on the clinical event, not only on the hemodynamic, but on the clinical event. Well, that will be the last talk, the added value. It's not the me too, yeah?
We
okay.
see some cases.
Yeah.
So I think next up are two, well, we've got 3 cases really lined up. So representative cases from the Landmark randomized control trial. I don't know who wants to start. So we've got Francesco Bedoni and then Fausto Ferres and then Axel Linke.
Okay, thank you for the invitation. It was a very extremely exciting study anyway. So I will represent a typical TAVI case representative of real-world experience in our center. These are my conflict of interest. And this is a 87 years old woman, so a little bit older than was the mean age. But you know, Italian ladies are very fit, so no problem about that. So no previous cardiovascular history. She had a quadrantectomy for breast cancer. Severe aortic stenosis, mean gradient is 59, so, and a low reduction of left ventricular function, pulmonary hypertension, and a normal renal function. This is the echocardiogram. It shows important hypertrophy, calcification of the valve, pleural effusion, and a severe aortic stenosis. This is the procedural scan. You'll see this is the annulus diameter. The annulus area is 482 millimeter square with an annulus dimension of 25.3. The LVOT is comparable with the annulus, and there is the calcification not so important in this case. Important is to see the femoral access. You'll see there is some calcification. The lower size of the iliac artery, 6.4, is a little bit tricky for my valve, where the minimal lumen is 6.5 for this approach. Anyway, we choose the left femoral access, and the valve and the area is compatible with the 26 millimeter my valve, octator my valve, and we use obviously the Python sheath. And we start with the procedure. We check the femoral access. You can see that in fluoroscopy there is some calcification. Anyway, we could cross the 14 French Python sheath. It's an expandable sheath, so we go through the calcification and descending aorta. This is the three-cusp view aortography, and we give a pre-dilatation with a semi-compliant 20 millimeter diameter balloon. So at that point we are ready to implant the valve. So we start with the valve. The first attempt, but we were stuck at the external iliac artery, between the external and common iliac artery, so we couldn't progress. At that point, due to the fact that the valve is crimped outside of the patient, we could retract the valve and dilate the Python sheath inside the Python sheath with a 7 millimeters balloon to ameliorate the situation and to give a good tract to go through. Next, second attempt, and we stuck again against the same place. And so at that point to try to post-dilate more aggressively with the 8 millimeter diameter balloon. After that, we obviously working on a femoral artery, we lose the wire, no problem. We pull back the valve again, and we recross the valve, and we put again the Safari. And at that point, after the 2 dilatation, we could cross through the really calcified aorta. And this is the most simple thing to do is now to implant the valve. This is the implantation. The markers help very well how to implant the valve, the position, the very precise positioning. This is the final result. We check, obviously, the femoral access to be sure that there are no complications after the post-dilatation of the Python sheath, and we could, due to the fact that there's a correct commissural alignment, we can perform a commissural alignment in crimping the valve. We can really easy insert our catheter in coronary artery. So the take-home message of this case is that crimping the valve outside the patient gives the possibility to retract and insert the valve through the Python sheath in case of failure of the vance or in case if we lose the wire in the left ventricle. We can perform a PTA inside the Python sheath if we have problem, and the commissural alignment allows an easier coronary access. Thank you for your attention.
Thank you. Fausto, we move swiftly on to the second case and then the third. There are some questions coming in. We'll address them after the cases.
Thank you, Andreas. Thank you, Patrick. It's a real great pleasure being here. I'll talk on behalf of our team in Brazil, Alberto Cervoni and also Dimitri Siqueira and all the research teams. And I would like to thank to Meril Life Sciences that gave us this incredible opportunity to be in this landmark trial. And also the PI, my friend Patrick Serras. We started almost 4 years ago looking at all this presentation about wall stent, drug-eluting stent, Palmar shot stent, brachytherapy, syntax, and now he brings this incredible landmark trial. So what I'm going to discuss with you in this real-world case, we do not have any conflict of interest for this presentation. And we were in this trial in the last 2.5 months. And we could include 22 patients. It was incredible job for our research nurse and everybody there in São Paulo, Brazil at Dante Pazanese. This patient is 78 years old, a female, non-frail, with several medications, with STS score 3%. So the echo showed the ejection fraction of 64%, valve area is 0.6 millimeters, square centimeters, and also the gradient was 40 millimeters. So if you look at the bi-dimensional, it was a small annulus, as we have seen here, 1/3 of the patients, and also a lady, 416 square millimeters. And the SLV was less than 30, as you can see here. And also, the risk assessment for coronary occlusion during TAVR, if you look at the RCA, is 14 millimeters, and left system is a low takeoff, it's 8.4 millimeters. But left cusp length was larger than left main high. When you do an additional assessment for coronary occlusion during this procedure, we have a VTC of 5.2 millimeter, that was good. And also, the left cusp calcium volume was 320 cubic millimeters. That was good too. With a good vascular access, no calcification, and even tortuosity. So summarizing, 78-year-old female, non-frail, with anatomical challenges for TAVR, with a low coronary takeoff, a real-world patient. And after heart team discussion, came this important question: what would you do at this point? CAVR, TAVR with a balloon expandable, or with a self-expandable? So this patient was randomized to landmark trial to receive a balloon expandable, the MyValve THV series. As you can see here, the vascular access by ultrasound, and we do also an aortogram, as you can appreciate on your right. And now the evaluation of hemodynamics with a peak gradient of 46. And the predilation, it's very important at this point. As you can see, the white line sign that is favorable to avoid a coronary occlusion. That's important. As you can see, during the balloon inflation, the predilatation could be doing without predilatation, but predilatation was so important for this. So this is position of the valve. As you can see, we did the implantation a little bit down to avoid the coronary occlusion, as you can see here, and the deployment during wire pacing. That's our routine, 180 BPM. And now it's important, as we do in our routine practice, multimodal image evaluation, as you can appreciate, aortogram by echo, and also an invasive hemodynamic. And as you can see, the peak gradient was 6 millimeters after implantations with no PVL. So the patient was discharged home the day after the procedure, a minimalist approach with only sedation, asymptomatic. At 1 month follow-up, the patient reported improving her symptoms with the New York Heart Association Class 1. If I could summarize for you, that's essential to remember. Landmark is a real-world trial, real-world, small annulus, as we saw here, 1/3 of the patients, and women, 84% of them. Low coronary takeoff in this patient, we need to include all the evaluation, even the three mentioned. The additional CT analysis by three mentioned showed the VTC larger than 4 millimeter and calcium volume less than 600 cubic millimeters. Finally, the procedure was important to do a predilation angio to further assess the risk of coronary occlusion. We did not protect because we did not need. And finally, the multimodality imaging evaluation post-EAVR is very important. So, and here you can see this real-world patient that was treated in the Landmark trial. Thank you.
Thank you, Fausto.
Yeah, last but not least, case on the other side of the range. It's a pleasure to present this on behalf of the Landmark investigators. These rheumitis closures. The patient I'm going to present is an 83-year-old man with hypertension and with severe heart failure as comorbidities. He had VT and was implanted with the CRT system years before. He had additionally coronary 1 vessel disease that was addressed by PCI. He had AFib in addition, moderate degree of mitral regurg, hyperlipidemia. He had suffered from cancer 5 years ago, but was successfully treated. Physical examination shows heart rate in the upper range with 84 beats per minute. And he had, due to his comorbidities, high surgical risk with an SDS score of almost 11 and a Euro score 2 of almost 12%. He didn't suffer from angina, but he had severe shortness of breath. As you can see here, the left ventricular ejection fraction is severely impaired, around 30%. And the valve orifice area was 0.8 square with a peak velocity of 2.7. Aortic regurgitation was only trivial in this patient. The three-dimensional report revealed a quite large annulus with a perimeter of more than 100 millimeters. The perimeter-derived diameter was 32 millimeters. And in addition, his ascending aorta had some kind of an unusual shape and appeared to be oval. As you can see here on the lower right side, there was a lot of calcification, diffuse patterns throughout the aorta. And you can see this and appreciate this diffuse calcification also in the femorals and the excess vessels, but from the site of the puncture all the way up to the aorta, we had an appropriate size of 8.8 up to 11 millimeters. According to valve size, the 32 millimeter myovalve series would result in a 1.9% oversizing, and this was finally the valve that was selected for this kind of a patient. You can see all of the wires here. He had prior ICD implantation, as I said, CRT. You can appreciate the orthography here, and in addition to the pre-dilatation by the balloon. And with this 26 millimeter balloon that is fully inflated, you can see how big the annulus really is. Coronary height was around 14 millimeters, so there was no risk of coronary obstruction. You can appreciate the nice valve crossing. We always know that in patients with an elongated aorta, this is sometimes difficult, but despite of this, the valve was nicely trafficking through the arch and could be positioned easily across the calcified valve. As it is often in those cases, the valve has, in the initial positioning, some kind of a a typical position. But as you can see from the implantation view, the valve nicely self-aligns and is finally in the right spot as anticipated. It's important not to start too high up here in order not to risk any kind of valve embolization. During valve implantation, the patient had a short period of sustained ventricular tachycardia that required defibrillation, but apart from that, the implantation was uneventful, and you can see that the valve is nicely fitting into the annulus with no overt aortic regurgitation. After the procedure, the femoral excess vessels were checked, and there was no evidence of bleeding here from the excess vessels. Post-echo revealed a valve orifice area of almost 3 square centimeters with low gradients. Cardiac output had increased considerably, and the injection fraction improved. And the values were also stable in the 1-month follow-up. This was not expected that the left ventricular function would normalize, but again, there was no evidence of aortic regurgitation and stable valve hemodynamics. So in summary, in this elderly patient with high STS score and multiple comorbidities, the MyValve THV was successfully implanted without any peri or post-procedural complications. Hemodynamics were stable up to the 1-month follow-up with good echo results. The patient got significantly better with his New York heart going from class 3 to class 1. The valve has been used in different geographies, in different anatomies, and has to be proven to be safe and effective. And the expanded size range of the valve now enable us to treat patients with that had been able to be treated before. Thank you.
So all the time, Andreas is collecting your question, and some of them are really burning. But we will do 3 more talks, and then we will have plenty of time before closing this session to answer your question. We are just regrouping then. Osama, if you want to present your talk, which is insight from quantitative aortography at procedure and echocardiography at pre-discharge and 30 days.
This is because some of the questions will be answered by the talks, so
yeah,
it's more effective.
Thank you very much. Thank you very much for the kind invitation, and I'm honored to be here. So in the next few minutes, I will be presenting some insights from the aortography and echocardiography in the Landmark trial. This is my disclosure and this disclaimer of Meril Life. So as a background, you have here that this new technology of MyValve transcatheter heart valve series has unique characteristics. Of those, the intermediate sizes, we have seen the presentation of Ignacio, and the other is the controlled deployment strategy, plus others. We know also that previous observational data suggest a favorable hemodynamic outcome. There are several publications of the different series, but this is the first ever randomized trial that we are comparing 3 devices. Primarily the MyValve series against the gold standard of the TAVI technology. So we aim in this 8 minutes to use the collab adjudicated data of aortography and echocardiography to dive deep into hemodynamics in aortic regurgitation. So these are the VARC-3 TAVI or transcatheter heart valve performance. They are 5 components. It begins with the paravalvular regurgitation, or commonly aortic regurgitation. Then the THV intended performance, and the components are the mean gradient orifice area and index orifice area to body surface area. We have a unique, in this trial for the first time, you have 2 different techniques, quantitative aortography as well as echocardiography at 2 different time points to analyze the paravalvular regurgitation. So a brief about the concept of aortography. You probably been now more than 20 plus publication about this technology, and in the reference here I have 2 of these from our colleagues Modulo and Abdul Wahab in JACC intervention. And the technology in brief is simple. So you have, you inject at the final aortogram into the aortic root. So the reference area will be this aortic root. We quantify the density of the contrast, and we compare it to the LVOT area. What's the region of interest? If there is any leakage, you will see it there. And the regurgitation fraction or the surrogate will be in percentage, either absolutely no regurgitation, that's 0, or 100% free flow, that would be 1. So, and the relative ratio is this regurgitation fraction. So we develop a cutoff values for this just to make it familiar with the so-called mild, moderate, and severe, and that's 6. Below 6%, that's none or trace, and then between 6 and 17%, that's mild, and the moderate or significant more than 17. So the first results here, the analyzability index of this one for the first time, 80%. And that's very good in this population. And from those, 4% of the population, they have significant regurgitation, and that's the entire cohort. When we split this, as you see here, to MyVal series versus contemporary THV series, you can see the most relevant one is the one to the right. And you can see there are 6 patients in this category with significant regurgitation compared to 18 in the contemporary arm, which is really, you see with the p-value significant in favor of the MyVal series. However, this is not a brief, yeah, it is part of the analysis, but it's the main primary endpoint was driven on echo. If you give numbers here, which much easier for you to understand, this is surrogate of regurgitation fraction. Look for 3% versus 4%. It reflects 2 things. This is really contemporary TAVI practice. It's the best in class because all devices are really below 5%, which is really regurgitation fraction. And it gives numerically in favor of the MyVal series. If you use the mean plus or minus standard deviation, you can see also number here. And this is regurgitation fraction, again, below 5%. And in the contemporary series, 5.8%. So again, what Ignacio presented also, this is, you have per protocol analysis and as treated. As you see here, the post-dilatation was used in 10% of the arm of MyVal series versus almost twice in the contemporary arm, which was significant. Again, that would be a lot of analysis, sub-analysis on this. But for us, in terms of regurgitation, what is very relevant here is that regurgitation fraction goes down from 12% into 2% in the MyVal arm, and compared to, as you see, 12 to 5%. So it's very effective. And in this case, 83% reduction of regurgitation you could achieve during the procedure before you leave the cath lab. You go to echo, again, it's confirmed. You have seen this, but this is more details. And the most relevant here also, if you look for discharge and 1 month, the clean, we call it, no AR at all. It's here approximately 60% in the 2 arms. And you can see the mild one is also 40 to 35%, and the significant or moderate is very low in the 2 arms. Important to analyze or to read all numbers when come to the next slide in terms of this slide. So size matters here. So you have the valve site distribution. As mentioned before, 1 out of 4 patients in the evolute arm is a larger size, which is 34. And another one, the intermediate size, was only used in the MyVal series. So this is the last slide about the performance. I will conclude after that. So let us go here one by one. This is the VARC3 in performance criteria. Mean gradient more than 20. You see it's the same percentage, less than 1%. The AVV max here, you see 0.5 versus 1.3%. The less load-dependent dimensional ratio, or DVI, is less than 0.25, is only 0.3%. And finally, the moderate or more BVL was numerically lower in the MyVal arm. With the final total performance, as you see here, 95.3% in the MyVal arm was as intended, compared to 93.6%. Which you can conclude that at least comparable hemodynamics as pre-specified. So using aortography, discharge echo, and also 30-day echo, let us summarize 3 messages. The first one, using CoLab adjudicated data from discharge and 30-day TTE, it shows the excellent hemodynamics and AR performance of MyVal series in the first time in a randomized control trial. including patient you saw already with a typical severe aortic stenosis. And the core-lab adjudicated aortography also confirmed this favorable result. You have numbers with regurgitation fraction also to show you this in both arms. And of course, you have seen also that the post dilatation is very effective. So you can use it. You can use aortography to guide you to do that with a very efficient 83% reduction versus 58% reduction. The last remark is that you, as we all mentioned, so the long-term results up to 10 years are expected to confirm all of these initial findings. And that was my last slide. Thank you very much. Okay.
Thank you, Osama. Excellent piece of information. I mean, it's quite unusual in this trial that the aortography is analyzed quantitatively. That's what we do in practice, so it's better to quantify, and the methodology has been very well validated. So we will go now to Yoshi Onuma in Galway, which is going why and how the conduction disturbances were treated.
Thank you for the introduction. So my talk is about conduction disturbances and also the pacemaker implantation. So this is, I don't have any conflict of interest for this presentation. So as you know, the new cardiac conduction disturbances and arrhythmias are amongst the most frequent complications of the aortic valve procedures. This sentence are the excerpt from the VAC3. In VAC3, it was recommended that all studies at minimum report the baseline and post-procedure presence of the most important conduction disturbances and arrhythmias. So how it was evaluated? So in the Landmark trial, there was the ECG CoreLab circ located in Paris, led by the Professor Marie-Claude Maurice, and the CoreLab led all the ECG collected during the trial at baseline, pre-discharge, 30 days, and they will continue to read the ECG at 1 year and 5 years. Clinical endpoint, including new permanent pacemaker implantations, were adjudicated according to VAC3 criteria by independent clinical event committees shown in this slide, and they used the CoreLab ECG readings and or the other source document in case there was no reading from the CoreLab. How many ECG were analyzed? The Landmark trial has an excellent follow-up rate, only 3 in each arm lost to follow-up at 30 days. In all time point before procedure, pre-discharge 30 days, the more than 90% of the ECG was corrected and also analyzable. These were the changes in the PR interval before procedure, after procedure, and at 30 days. As you could see that after implantation of the valve, there was an increase of the PR interval by 21 milliseconds in MyValve THV series, by 15 milliseconds in contemporary THV arm. This increase still remained as significant, statistically significant at 30 days by 7 milliseconds in MyValve THV series and 3 milliseconds in contemporary THV series. QRS duration also increased after the procedure by 15 milliseconds in MyValve, 17 milliseconds in contemporary THV arm. Also, this remains consistently, significantly increased at 30 days by 10 milliseconds in MyValve series and 9 milliseconds in contemporary THV series. Pre-procedural conduction abnormality or arrhythmia are shown in this slide. This was reading from the CoreLab. You could see that there was no difference between the two groups, but the left bundle branch block was observed in 5% of the MyValve THV series, 7% in contemporary THV arm. There was also approximately 20% of the patient had the atrial fibrillation in the 12 leads ECG at before procedure. First degree AV block was also observed in 18% in both arms. After procedure, you could see that the left bundle branch block ratio, the frequency is increased up to 19% in MyValve THV series and 24% in contemporary THV series. First degree AV block was also increased up to 27% in MyValve THV series and 24% in the contemporary THV series. As you could remember, it's reflecting the prolongation of PR interval. However, at 30 days, this LBBB and first-degree AV block was somewhat reduced. So the left bundle branch block was observed in 12% in both arms at 30 days. Also, the first-degree AV block was observed in 18% and 17% at 30 days in MyValve series and contemporary THV series, respectively. How about pacemaker implantation? It was part of the primary composite endpoints. So in MyValve arm, 15.0% of the patients received a new permanent pacemaker implantation. Also in contemporary arm, the rate was 17.1%. What about the timing of the implantation of the pacemaker? So 9% in MyValve and 10% in contemporary THV arm, patients received the pacemaker after discharge, but the majority of the patients received the pacemaker between the 40 hours post-procedure and discharge, 58% in MyValve and 51% in contemporary THV arm. Majority of the case, ECG reading was available for the core-lab assessment, 74% in MyValve and 71% in the contemporary arm. However, approximately 1/4 of the patient, the ECG 12 read was not available, so the KEC was using the other source document to look into the cause of the pacemaker implantation. So these are the cause of the pacemaker implantation. First, most frequent cause of the pacemaker implantation was complete heart block, followed by the left branch block and then second-degree AV block. Also, there was one case of the alternating left and right bundle branch block observed in one patient in the contemporary THV arm. These are the pie charts to show the cause of the implantation of the pacemaker. So 79% of the case in MyValve, the complete heart block was #1 cause for the pacemaker implantation. Also, same observed in the contemporary series. Complete heart block was the cause of the implantation in 69% of the cases. Which type of the pacemaker was implanted? Majority of the cases, patients received the dual chamber pacemaker, 61%, followed by this single chamber pacemaker implantation in approximately 1/3 of the patients. There's no difference between these two groups. The next slide shows us what is the pacemaker implantation rate in the previous trials. So you could see that the pacemaker implantation rate in the Landmark was 15% in MyValve and 17% in contemporary valves. If you look at the trial, like recent one, SMART trial, the pacemaker implantation rate in SAPIEN was 8% and Evolute 12%. But if you look at the SOLVE-TAVI trial, which was published in 2020, the pacemaker implantation rate in SAPIEN 3 was 19% and 23% in the Evolute arm. So we think that our trial is in line with the previous publications and trials, and definitely there was no underreporting of the pacemaker implantation. Also, we have observed the variation of the pacemaker implantation rates per site. These are the data from the sites randomizing equal or greater than 20 patients. You could see in the MyValve arm the rate of the implantation ranging from the 0% to 33%. In the contemporary THV arm, it's also ranging from that 0% to 25%. This suggests that the pacemaker implantation rate is not only influenced by the type of the device, but also influenced by the strategy or the institutional policy and the local clinical practice, how to react on the or how to implant the pacemaker in case of the conduction abnormalities. So as a summary, in the Landmark trial, core-lab analyzed ECG prior to the procedure, at discharge, and 30 days. KEC adjudicated the events according to the BARC 3 criteria. From pre-procedure to 30 days, significant increase was observed in terms of PR interval and QRS duration. Prior to procedure, left bundle branch block was present in 5% in MyValve and 7% in the contemporary arm, and at 30 days, the rate was 12% in both arms. At 30 days, new permanent pacemaker was implanted in 15% of MyValve and 17% of the contemporary THV. In majority of the cases, implantation was performed between 40 hours post-procedure and discharge. The most frequent cause of the pacemaker implantation was complete heart block, whereas the most patients were implanted implanted with a dual-chamber pacemaker. When stratified according to the site randomizing equal or greater than 20 patients, the variation of pacemaker implantation rate was observed in both arms, ranging from 0 to 33 in the MyVal arm and 0 to 25% in contemporary arm. Probably this is reflecting the local clinical practice. Thank you for attention.
Thanks, Yoshi. That's really a deep dive. We've got a final talk from Patrick Sirois, the added value of MyVal THV to our practice. And then we'll discuss your questions.
Okay, what is the added value? Is the MyVal just another me too, or is there a specific added value? You have seen that. So what are the possible factors impacting the transcatheter heart valve durability? Clockwise, you have the initial trauma of the crimping and expansion. You have the stent frame expansion, the commissural alignment, the type of transcatheter heart valve, supraannular or intraannular, the coaptation of the leaflet, the valve thrombose resulting in leaflet thickening, and the potential impact of the antithrombotic. You have seen this slide many times. I have to tell you again that there is an ongoing extra-large nested registry in the trial. We are going for 120 patients, maybe 300. That's one key point. The second key point is that that valve, Evolute 23, was not used by the investigator. And if you look in SMART, it's only 2.3%. Yeah. So the next point is that this cartoon depicts the implication of intermediate nominal valve size on valve selection. On the vertical axis, we have the aortic annulus area in millimeters square, ranging from less than 300 millimeters square to more than 860 millimeters square. In red, we have the nominal size recommended by Edwards manufacturer with respect to the aortic annulus area. The SAPIEN has 4 nominal size, 20, 23, 26, and 29, with a step of 3 millimeters between each nominal size, and with very little overlap in the selection of the recommendation of the valve with respect to the aortic annulus area. A similar pattern is observed with the Evolute. However, there is a jump of 5 millimeters between the nominal size 29 and 34. So the MyValve series, with its array of 9 nominal sizes with small step of 1.5 millimeter between each nominal size and with a substantial overlap between each nominal size, facilitate the appropriate selection of the valve size and fit and match more precisely the aortic annulus of an individual patient. Now you have seen this slide. Obviously, even for a new technology, we embrace very quickly the concept of intermediate size. We don't like to be too big or too small. That's basically the dilemma every day in the lab. Now, that's an idea of Axel Link. During the writing of the manuscript, he made a short comment and he said, why you don't create a fitting index? And the fitting index is the nominal size of the valve in diameter divided by the aortic annulus diameter multi-slide CT scan derive. And you could see here you have an octa-core, 21.5 millimeter, that's an intermediate. The area here is 351 millimeters square with a perimeter of 67.1. So the fitting index in that case is close to 1.02 of 1. Now, what you see on the left-hand side is an histogram of the fitting index. In red, you have the sapien. In green, you have the MyValve. And when it is overlapping, you are in brown. Now, this is the same, but it's called a density curve of the fitting index for MyValve and sapien series. And you see there is two interesting regions here, which are not in the fitting index. So this is, again, the MyValve in green, and in red, the sapien. And then you see the fitting index of the MyValve and the fitting index, on theory, of the Evolute. There is basically no overlap. And I told you that they didn't use the 23 millimeter. Now, does that have an impact on clinical event? On this slide, we have the impact of the fitting index on clinical event. When the fitting index of the sapien is not overlapping the fitting index of the MyValve series, the area delineated by the x-axis in the density curve, then the percentage of pacemaker implantation is numerically higher for the sapien than for the MyValve, 20% versus 12.5%. It's not significant, but it is an interesting observation. When the fitting index of the two valve is overlapping in this region between X and Y, then there is no difference in the percentage of pacemaker implantation between MyValve series and sapien, 15% and 14.1%. And again, when you go beyond the threshold of the y-axis, then again you see some difference between the MyValve and the sapien, 17.5% for this MyValve and 22.2% for the sapien. Now, my father used to say, repetition is the mother of education. And personally, I want to see a slide more than one time, then I leave the meeting with the pictures in my brain. So you have seen that slide, but I will again comment. This is an animated slide. We show a green, the effective orifice area of the MyValve series for the conventional and intermediate nominal size. Ignacio have shown that. And the animation show the conventional nominal size for the sapien series, and for the 20 millimeter, as you could see, the effective orifice area are very comparable between the sapien and the MyValve, 1.42 centimeters square and 1.38 millimeters square. But for the conventional size of 23, 26, and 29, the MyValve series has significant large effective orifice area. Now, if we look at the Evolute for the 26 and 27, we are very close, or they are very close to the value of effective area in the MyValve. And then when we put all the graphic together, there are a significant ANOVA p-value between the three valve with comparable nominal diameter 26 and 29. It's interesting that you have here the value of the 34. Now we have a single protocol violator, so they use a valve of 30.05 in the trial. We keep in the trial. It's a violation, but in intention to treat. So we have one value there. This is the 30.5 MyValve with an orifice area of 330. So durability will be a decisive factor in the long-term clinical outcome. intermediate nominal size of valve is really a novelty in the field that has been adopted very quickly by the practitioner in almost half of the cases. The fitting index and the repercussion of a more refined selection nominal size of valve with respect to the anatomy has, of course, to be further investigated in larger number of patients to unravel where there is a clinical impact on pacemaker implantation and paravalvular leak. The equivalent or superior effective orifice area of MyValve series when compared to contemporary series is a major finding of the Landmark trial. But the multifactorial determinant of that superiority has to be elucidated. Is that the effect of anticalcic solution? Is that the improvement in valve structure to the valve frame? I mentioned that many times now. And will the long-term follow-up of the Landmark trial demonstrate the clinical benefit of a superior effective orifice area? Now, I think it's time to have discussion. Andreas has really collected a lot of questions, and the more difficult is the question that we will enjoy. Yeah?
Right. Yes, there are some questions, some clinical questions will probably be better suited for the later TNT. I'll give you the details. One question for you, I think, Patrick, and then we let you off the hook. Are there data to, can you provide data on post-dilation MyValve versus Sapien? Is there a difference between the two given by the sizing?
So when we send the material to the Lancet, we stick to the MyValve and the contemporary. And you have seen the number, 10% and 21%. So it's a ratio of 2. And that has a p-value of 0.45. Now, if you ask the question, and the reviewer asks the question, what is specifically the MyValve, the Edwards, and the Evolute? And then the numbers, and it is in the manuscript, is 10%, 10%, and 32%. That's the answer to your question.
Okay, so no difference between the MyValve and the Sapien, that was the question, and many more post-dilations in the Evolute arm, as is clinical practice.
The post-dilation is something which is very complex. So we have looked at why you do a post-dilatation, because, you know, post-dilatation can be dangerous. I mean, you can have stroke, you can have ruptures, you can have a pacemaker implantation that you didn't have before. And in the case of, we elucidate that sometimes it was the gradient. People were measuring the gradient and found a too high gradient. They react. Sometimes it was a PVL and they did a post-dilatation. Sometimes they saw a deformation of the valve in the frame of the valve and did a post-dilatation. And I must say and confess that in the case of Evolute, they were sometimes routine post-dilatation. There was no justification. They just post-dilated.
Right. Clinical question, maybe Daniel. In the minimum, if the minimum diameter for access with the MyValve is 6.5, that's the IFU, 6.5 millimeter for access vessels. Could you please explain how this affects choosing the patient? As in real world, we often see smaller vessels. So I would like to understand if highly calcified patients can be treated. I think we've seen a case where you dilate it, but what's the answer to 6.5?
Well, 6.5 is perfectly fine, even for the
And smaller?
6.5 will fit the XL sizes just fine. You need only to remember to pre-dilate the expandable sheet with the 18 French dilator that you get inside the kit. As for smaller vessels, we have treated. Sometimes you can encounter cases like this, but the good thing is that you can pre-dilate the sheet from within, as perfectly illustrated by Francesco. And sometimes being a surgeon, I don't escape even the opening of the femorals to find, first of all, to find the soft spot where you can actually then do your puncture, and you are sure that you'll be able to close it, and that you won't have any failures of closure devices, or that you won't get into very, very bad situation of having the bleeding and putting the balloon on the other side, which all complicates the procedure, and of course you end up with worse results. But the worst calcifications we have encountered are those that are actually circular and that are close to the bifurcation. So sometimes they are very, very hard to cross. We have tried, and then this is something where shockwave won't do you much good. And even though we have also done cases with stenting in such cases, and we were able to advance the valve through that. But then you will need to be extremely, extremely careful in retrieving the whole system, be sure that your balloon is off, and retrieving through that stent, retrieving also the introducer.
So basically not different from what we're used to.
No, not really, no.
With other systems. No. Maybe a last, there's a lot of clinical comments on there, not real questions. Vlasis, there is one very clinical. There's been shown at least 5 cases during EuroPCR now with MyVal, and all with pre-dilatation. Mia Susteris says, we use MyVal and do not do pre-dilatation, and the implantation was successful every time. So if the valve does not pass, you can still do pre-dilatation. What's your question? So the reason being the system is very flexible, but also a bit softer, and some people feel it has less push and prefer to predilate.
That's a very interesting comment. I mean, that's clearly up to the operation discretion how to manage these cases. Personally, I have low threshold of predilating patients. I feel that it makes life a lot easier when crossing the valve, and potentially you don't have stored energy on your implant when you inflate. Having said that, the beauty of the system, since it's preloaded, as we've seen in the case from Francesco, is if you cannot cross, you can take it out, you can predilate, and you can put it back in. So you're not committed once you get into the patient's body that you have to implant it somewhere. You can take it out and you can modify your strategy.
Thank you very much. We'll close with one comment. Clemens Steplovich says 10 minutes ago, of course, the fitting index for the Evolute is higher. It's supposed to be oversized. That's a comment I think that should be made. If there are any further questions, come up to the microphone. There is one more. That'll be the last.
I want to make a little comment about the 14 French sheet. If all sizes are available, you can use with the 14 French sheet. But for the larger sizes, a little amount propofol inside the sheet. It's very easy approach without any balloon dilation.
Yeah, and
it works.
It calms the operator as well.
And the second is about the pacemaker race. You know that we published also our registry newly, and our pacemaker race with MyVal was 11%, but then we begin to use high deployment technique. I think new octacore is coming, and there's a radiopac marker on it, and it will be, I'm sure that the pacemaker race will be lower.
That comment is the perfect segue to an announcement of the next session about this topic. There will be one more. Clinical questions can be addressed there. There's a tools and techniques session on this level, Theatre Bleu, at 4:30 this afternoon, including a recorded case and many more opportunities to ask clinical questions about this technology. So with this, I close the deep dive into our randomized landmark trial. I hope we've answered most of your questions. Thank you, Patrick, and thanks to the panel.